So let's connect now, going to Mount Sinai Fuster Heart Hospital. First and foremost, Dr. Kini and Dr. Dangas.
Hello from New York. Do you see us?
Yes, we see you, Dr. Dangas.
Hello from New York once again.
Yes, can you guys hear us?
Yes, the fellows. Yes.
Go ahead, Dr. Kini.
All right,
Roxana
excellent.
and Ajay and the entire panel. Thank you for inviting us for this excellent session. We've been watching it ever since it started. Myself, Dr. Kini, and I have Professor George Dangas, who's going to be helping me with this live case. We have Denizan and Pierre as our fellow, and the rest of the team. Actually, Kiski will be the one who is our faculty for the imaging. So I'm going to show you the slides, if you can start seeing the slides. So actually, I put it as case 2 because we did our first case last year for TIO. So this is the second case we are doing this. First case, for this session from us, which is a 92-year-old male. Though he's 92, very active, he's an accountant and he still works. Presented yesterday with unstable angina, troponin was still negative. He had risk factors for coronary artery disease and prior PCIs like you see here that have been done in the past. So angiogram done yesterday did show that he had 3-vessel disease. Culprit was the distal RCA, and he had significant left main as well as the LAD disease. I'll show the angiogram. So this is the right coronary artery PCI that was done yesterday.
Very calcific as well, as you see.
Yes. So today the plan would be to do a high-risk left main PCI of a calcific lesion, and we always see what is the predicting patient risk factors. Like we know, we do use STS as well as the syntax. STS was about 31, syntax 2.2, despite him being a 90-year-old. And we always use appropriateness criteria. With left main, always is a surgery is the most appropriate, but with this age, I think it becomes M. So if you can go to the angiogram right now. Right coronary artery today looks beautiful. And here we are with the left. So significant distal left main. And what you see there is aneurysmal look, both of origin of the LAD as well as circumflex. I just doing this, poor man's view of understanding calcium, tram track calcium, even before we inject any dye. And this is a cranial picture.
So you guys wanted a complex case that includes calcium and bifurcation. So we thought we'd give you 2 bifurcations in one case, left main and LAD diagonal in combination with aneurysmal disease of the side branches. We can undertake some discussion.
So we've got a great panel here.
That we try to do some imaging. The catheter wouldn't advance, so we prepare right away to perform the rotablator 1.5 burr because nothing would advance through that. So with this knowledge, go ahead with the discussion.
Yeah, so let's go to the panel. Ajay, it looks like you want to say something. Some will say, well, you couldn't pass the imaging. Maybe you use a very small balloon and still come forward to use the best possible technique for your ablation. But let's hear from you, Ajay. Any comments?
Simple, basic
Can't hear
things that
you.
we don't talk about enough.
Okay.
You can't hear me? Can you hear me now?
Now I can hear you. Now we hear you. Go ahead.
Just some simple, basic things that we don't talk about enough that shows, the experience of not only Dr. Kini, but the whole Sinai team. First, they took the picture of the right coronary artery before starting on the left, even though they fixed it yesterday, the day before. Because if something had happened there and you didn't know about it, and you embarked in this 92-year-old on treating an unprotected left main, you wouldn't know. So things like this, very basic steps are really important in the case. Similarly, you can be very dogmatic about imaging, but if the imaging catheter doesn't advance, you don't want to shove it through and make him very ischemic. So you immediately make the decision for rotablator. You do it quickly, efficiently. Again, I think because of the experience of the team, they don't need to use hemodynamic support. They do this in a very straightforward fashion. But these little steps are really important for these sick patients.
Absolutely. Any comments, Natalia?
Neo, please.
Yeah, I was just thinking myself when I do these cases, if you use a balloon to get your catheter in, you will have like the Roda ablation regret. So I think this modern belief that if the imaging catheter doesn't go, then you're likely going to need Roda ablation or CSI or orbital ablation. I think it's a great approach because this case has not only severe calcium, but very extensive. So you don't want to be here. You won't do one inflation. You will do several inflations in the left main and LAD, risking the flow. So I love this approach. If the imaging catheter didn't go, then you go to ablation.
So Dr. Kini, tell us, what did that feel like? It felt like you really had to work hard to get through the calcific length.
Well, the 1.5 burr, yeah, we selected the 1.5 burr because it was clearly small on the left main part, but it was very adequate in the LAD diagonal part, and you saw very clearly. Keep it straight. You saw very clearly that they struggled a little bit in the second lesion. Why again? Because it's really appropriately sized more for that lesion. If it was solely a left main, 1.75 burr might have been undertaken, but clearly we try to do the very stepwise. As you can see, put the burr up. We use Dyna to actually put it a little bit in the left main, just a little bit align it out of the guide. And then it was a very slow movement, stopping every 10 seconds in order for the vessel to breathe. There was no hypotension. The patient went blood pressure was systolic about 100. We supported it with a little bit of neo, just preemptively, one can say. There was no bradycardia. Heart rate remained at about 50, as it is right now also. So no major event hemodynamically. And what about the wire side by side with a run through now? And following that, we're going to give you an OCT imaging of this situation.
So I think, like George mentioned, as I was at the second lesion, you see that? Just at the level of the diag, I was having some issue in advancing. So we had to do 3 runs, but it's aneurysmal, so you got to be a little cautious. If it had not gone with the third pass, I would have just come out. There's a risk of perforation when you are at this level of vessel.
Well, that's an interesting point.
If you really need something, you may have to downsize the burr because we were at 1.5. And like you mentioned, you needed 1.5 for the left main. Probably it's a little small size for the left main. And let us see if we can do imaging now to understand what the rotational atherectomy has done. I just want to show another point for any fellows that are watching, that if you see here, so I didn't want to do multiple views, so thought let's wire in this view. Now, in the cranial view, I kept getting into the circ because the way the aneurysm is probably facing. So you try a little bit. If it does not, immediately change the view. So in the caudal view, you see that my wire was just kept getting into the circ. So you then change your wire movements. You see that, your finger movements, so that it is facing up into the LAD, and then we are able to get into the LAD.
OCT.
Yes. Now we will see if the OCT catheter will advance at this time.
Yeah.
Was that a bare rota wire that you used originally? Did you go
Fill-
straight with a rota?
Microcatheter.
Filter first with a turnpike and change for the rota floppy wire. And just to complete the aspect that very eloquently Dr. Kini brought up, if the 1.5 burr wasn't advancing and we wanted to do something better, the three options. One is you increase the burr rate, RPM. The second one, which of course is in this case would be risky. The second one is you downsize the burr to 1.25 in this case, and the third one would be to change the wire into the rota extra support and the rota floppy. So I think that's very teaching point. These are the three things that can
Give me
be
a
done
bigger syringe.
in general. So right now we're getting to ready to continue here from here.
Okay.
We're ready to continue and inject
Open.
for the. Don't worry about this one. I'm gonna inject from right here. It's fine, no problem. We'll inject here. We're gonna do the. Go forward this way. We're gonna do the OCT right now and doing the setup to inject the very large volume that needs to be injected. In order to create the column of contrast that's needed.
Okay, so
Let's do a little test to see where we are. And again, you got to pull the guide a little bit. I don't know, but
some dye? Yeah.
no, it's
see,
not.
then it's
It's
not.
not going to be.
It's a little dangerous, tricky situation here.
All right.
Nice
Let's
clearance.
we need the
Okay, 1
14.
second. Enabling 1 second.
Let me know. So I'll
Calibrating.
do a synchronized
1 second.
injection here.
Yeah, please, Sinai, inject.
See there? And I'm injecting now, and the whole thing goes back
Yep.
very nicely, actually. But the guy popped out just a little bit in the end, and I think we're gonna have the whole vessel. It's very important this imaging because with a new system of the OCT, we can do many more sophisticated analysis very easily, and we're gonna see it very soon. We can not only see the side branches very clearly in their location, we can work in a longitudinal view, and we can see we are pre-marked to see only the arcocalcium over 180 automatically. We can do measurement of lengths, very important in this particular case, but also automated measurements of not only the lumen but also of the vessel EM in different cross sections, and we can see all those things laid out in the longitudinal view that Kitsuke is ready to summarize for us.
Sure. So I'll start from this is the after the
Show
D1.
Kiski?
Yep.
No, I'm saying them. On
This
the
is after the D1, kind of aneurysmic part. So now come to the level of the D1.
Tell them in the longitudinal view what is the left main and what is so they orient themselves down there, and then show them the cross section.
Sure. The new software show the left side is the proximal, the right side is the distal. So I will start to work from the distal. Now it's a level of the D1. And I now come a little bit proximally. So you see that already we did at 1.5 burr. The surface of the calcium is shaped a little bit. But now come to more proximally, like through the vessel, a lot of calcium. Like this is all calcium, like a 270 calcium. And now come to the proximal LAD. This is the proximal LAD aneurysmic part. So now come to the distal left main. It's definitely tight, like a 2.4 area. And even the proximal LAD left main has a 360, very thick calcium. Like all the way proximal left main has a all diffuse, and osteo left main has a calcified nodule also. Total length is 36. Left main size is like 4 low, but LAD size is like a kind of a 3 or something like here. But start of the program.
Okay, distal left main, tell us, you think rotational atherectomy has done enough? Do we need extra?
We need a little IVL in the left main.
Yeah,
Distal left main.
I think a cutting balloon.
Cutting
I was
balloon
gonna-
or a shock or a shock
Yeah.
shockwave. I wonder what would
pressure
you
balloon, what you're gonna try right now.
Yeah, I think that it's a relatively short area of super thick calcium. So I think the NC balloon is a
but
reasonable
down
way to go.
distally though, I saw a lot of lots of calcium. What did you guys think? I mean, I probably would opt for a shockwave here or a cutting balloon or something more than just a high pressure balloon. What do you all
Yeah,
think?
I think,
Natalie?
Roxana, the anatomy of the calcium in the 3 orange segments detected by ultrasound had almost the criteria for an IVL. It's like superficial, very thick calcium that is like circumferential. So problem with the IVL, now we have the 120 pulses, but it's hard when you have multiple segments with this calcification. But at least the distal left main is very thick calcium with a good lumen. So I suspect rod ablation is not going to do MASH modification at this point.
Higher.
You know, and this seems to be expanding pretty well. I think the problem is that so that you know, we think this is best with IVL has not been tested in a randomized way against balloons, and balloons often will work. So let's see what happens with the repeat imaging. One thing I would also say about this system is that, you know, we're used to interventional meetings where people always show the new, latest, and greatest thing. And you remember your iPhone, it gets updated every year. This update with Ultron is not like your every year iPhone update. This is legitimately, and you know me, I don't say these things very lightly, but it's legitimately a really, really big improvement with the system compared to how it was before. And so I think that folks that haven't seen it yet will really actually enjoy using it.
No,
and one question: Are they using NC or OPM balloon there?
Ready? Set up.
I think it's an NC balloon.
Balloon, high pressure, yeah.
Was NC 3O balloon at 22 atmospheres proximally and at 16 atmospheres distally. I think in the distal part we did a good result. And by the way, you can watch now in the OCT map that we have at the bottom left. You see the orange zones are exactly where the calcium is over 180. That's pre-marked. And you can see the round dots are where the side branches are. So, and the total length is 38 from osteo. 36, and we have marked where the 38 stent can go to cover a 36 millimeter lesion from exactly where we started imaging, which actually kind of generous because there is an area of a good landing zone after the second diagonal. So we plan to go with a 38 long stent. The question is how everybody feels and how Dr. Kini thinks about the distal left main. And
go back to the distal left main.
Should we do a 3-5 cutting balloon there?
Yeah, so
Let me ask Ajay, why did you say go with a cutting balloon and not IVL?
Well, I mean, we're doing a trial to look, but one of them is about, you know, $4,500 cheaper than the other. So I figured, you know, maybe we would try that. Also, the length was not that long. And so my feeling was that if you could affect the fracture with the cutting balloon, then that would work. I do think you have to go up again, though, because I don't see a good fracture in this proximal area.
Yeah, I feel like the left main is not adequately done unless you re-image. But maybe I can hear from Joost and David. Joost, what would you do next?
Well, I agree with Ajay. I mean, there's a huge calcific volume in the left main. I don't think the balloon did a lot, but I think the only way to know is to repeat the imaging and see how this lumen area of 3O in the left main increased. And if that now increased to 6O, I think you did the job. If it didn't, then it's time to move up to either shockwave or cutting balloon. Which one is better? Nobody knows. But you need to test and re-image.
We need to test it. Let's, and David, you agree with that? I think I like to see an imaging. I'd like to see the image for the left main.
Yes, I'd also happy to use the cutting balloon here first. I mean, I think it's extremely likely that you're going to need to do a bit more than you've already done. The cutting balloon is cheaper. You can use it several times.
You want imaging again, no? You tell them.
No, we cannot do imaging.
I use
No, you're doing the dilate again.
Almost uniformly. You know, it's partly a cost thing, but it's extremely effective. So I would do that first myself, and then see what we've got with the imaging.
Yeah.
Dr. Kini, what are you doing next?
So we decided to go with a 3-5 IVL, which is going to spare further imaging in order to save dye in this very old person with 2 procedures within 2 days. So we're gonna. The criticism is well taken, and we're going to do several inflations with this IVL 3.5 in the left main area. We feel we have a very adequate advancement in the. Pardon.
Ah,
A little bit
no.
more. A
Little
little bit more.
Good enough. This is a 3.5.
Okay, bang. IVL, deliver. We need to go a little bit in.
You want to know?
Yeah, we don't cover the. Oh, yeah,
LAD?
maybe we're okay.
Yeah, very good.
All right. Well,
Like I said, it's
What is the
120.
team- What is the? I think the
impulse.
panelists are understanding why you're doing this. So they,
Yeah, no, this is very reasonable.
obviously,
Nobody's-
it'd be great to, yeah.
Yeah, in fact, the morning discussion was exactly, we don't really know. And so this is a very good strategy.
In our last angio, the LAD was bigger than the left main at this point. So we want to get a better expansion of fentanyl.
I will. Now get into the ostium. Yeah, because we have to come up to the ostium.
Yes.
Yes. A lot of dampening. Okay, go.
I hope it
This 3.5 looks small. So you said left main was 4.5?
This EER is 4.5.
Yeah, that we are not
But
going.
I think 4 is a
So how
improvement.
many
Safe
people
one.
We'll stay back in
wanna
the-
use,
We'll do OCT now. Get
protection,
OCT.
here. You know, this is a very, very high risk intervention in a 92-year-old.
Okay. Let's put it a little bit more.
Anybody on this panel would want to have Impella? These guys are doing just fine without Impella.
Okay, go.
David?
Yeah, no, we wouldn't use Impella. I mean, we would in the trial. We were in a trial with it, but otherwise, we don't. I think as long as you've got wires down the vessels and you don't lose
Down.
the vessels, you're very
Okay, get
secure.
OCT ready.
It doesn't have really horribly bad left ventricular function. Yes, it's a high risk case, but we deal with high risk cases all the time. And I think Impella sometimes gives people a kind of false sense of security. Because of course, in itself, it's offering a certain amount of risk to the patient in implanting the system. So I mean, we use it very rarely in the UK.
Dr. Kini, why did you choose against Impella here?
Yes, Impella. Access was borderline.
Access,
What do you think?
Borderline access in an elderly patient with EF of 54. It's like not a true indication, though it's a complex PCI.
Yeah,
Yes.
definitely a complex PCI, but let's do one
I'm
more.
glad to hear it.
The biggest challenge.
No, exactly. Because
Biggest
remember in
challenge
Excel,
with all the MCS is access. Yeah.
Yeah, and also I want
Ajay?
to let everybody know this case is very complex.
Go.
We have a PRU level of 140 on Plavix to respond to the patient. A little bit back.
that's great, George.
Okay, let's do one more.
But I would also say that, in Excel, that MCS was used in
Right.
a very small fraction of the cases, less than 5%. And for a normal EF, you fix the right. I don't think you need it. So you're exposing the risk.
Well, I mean, in
of
all
vascular
honesty, we are
complications.
inflating in the left main.
Ruptured.
We're after
I
in the
don't
left
like
main. We have in the left main quite a bit of time. So Impella might have been well taken. Let's see where we are now. We're removing the balloon.
Did you guys see that there was a rupture of the IV?
Yeah, I saw that the balloon ruptured in
Yes.
that ostium of the left main.
Have you had that experience? We have had this experience now.
Yeah.
In
So
many
the
cases.
pressure remains 140/80, so that we know.
So
We'll take a look picture.
Okay, let's take a quick picture.
Yeah, no, it's definitely folks have been reporting this occurring.
The OCT.
And sometimes with some
Yeah.
pretty severe
Good.
dissections,
very
but
good
oftentimes
expansion.
not.
Very good expansion.
No,
Want to do OCT or just put a step?
Now, ideally,
no,
we have
don't
to
inject
do
anymore.
OCT to
Just put it-
understand. I think I'm just going to look
Yeah, I
at
think
the left
given
wing.
all
We
of the
already have
dye,
dissection. I'm just going to
telling
stent
you
it.
for the-
Yes.
Yeah, just stent
Yeah,
it.
let's stent
Don't,
it.
no OCT.
No. Stent.
Yes.
3-0. 3038. What is
Yep,
it?
that is
So
correct.
what we'll do is we'll take a 3038. We start from the diag level, come all the way to the left main. If we may need another short one in the left main. I
No,
think
we'll
we'll
be
cover
fine.
it. Yeah. Now D2 had a lesion before we started, and we knew we are not going to touch that. Yeah.
Yeah, there is an intermediate
thing,
lesion,
the
60 to
3-0
70% in the second diagonal.
The only thing is the 3.0
Yeah,
may,
we-
depending on the
leave this
stent
alone.
type, may not go up big enough in the left main. Is the only thing. So
Yeah, that's
you may
what
be
I'm
better
worried
off
about. That left main is-
undersizing a 3.5.
Left main is a 4.0 to 4.5. But
We're definitely
Yeah, I would-
planning to post dilate the left main.
No, they're saying they go 3-5.
Too big. No, it's fine. No,
Put a 3-5
too big for the
undersized.
vessel. Can I get a dissection?
true.
Undersized, deploy at 10, and then we posted a left.
No,
Yeah.
it's just fine.
Okay.
It's very risky.
Professor Dangas
It's
is
very risky.
doesn't want to
4.5
take
in
that
the
But question for you: which stent are you using? Because it actually depends. Which stent is it? Because it depends
Zions.
a little on which stent you pick.
We're using
Yeah,
Zion's.
Science was used yesterday that's one thing we follow. That was used in the RCA. I know it's only one day.
The Science TIO is not going to get
no,
to
let me put
4-5,
the
I
stand.
don't think, in the left main.
No, it'll get up to 375.
let me
That's
take
the only
out-
challenge.
I have a feeling you're going to need another stent anyway in that proximal area.
Okay, let's see about that.
Okay, now some die.
Okay, come a little back, please. Way too
yes,
much.
Yes. Okay.
Yeah, it's good.
Come a little bit back. And a little bit back. We'll pick
want
that
more
right.
back? No.
Yeah. A little bit
I
back.
think we put another
I think
short
so.
stent in the
A
left.
little bit back. No, that's up.
I would go
See
for
that?
the second stent
Let's
in
see
that
this.
left main.
Good injection. We're perfectly fine. Let's take it up here.
Yeah, it's
Hold on,
exactly
hold
OCT shows.
You're very good.
Distally. Okay.
We're on the fat part.
Okay.
I think
Good.
you're.
Go,
I think
go.
you're right.
We may need a short 8 in the left main. That's okay.
All right, let's see about that.
Now after this we can do the OCT. Yeah.
Okay, let's come back a little
Now, other
couple of
question
millimeters
also,
back.
you see that I tried to wire into the LED. It would not go easily. So we just took the D2. That's one. And the
left back.
second, we knew we were going to do OCT. So trying to be in a
little bit back.
reasonable size vessel.
Okay, oh,
Yeah, good.
All right, we're
Guys, are
definitely
you doing
dilating
the
all the way
contrast
out.
injection
Okay,
for the
good.
OCT with the manual manifold?
We do.
Say that again. I'm sorry, we didn't hear.
But we have assist also.
No,
No, the reason I'm asking, given the fear for too much contrast, if you dilute the contrast in the syringe 50%, you get excellent images. That could be an option.
okay.
But left main is not covered.
Your vein is covered.
Ostium, not.
The ostium may not be covered.
All right, let's do the.
Yeah.
Well, that's why we have OCT right now.
Okay, now we can do OCT.
OCT right now. Okay, excellent.
That looks pretty good, guys, so far.
So,
Watch your wire.
Yes. No, I took it out. I'm trying to see if I can get into the LED.
Yeah, you want to go down the LED.
just let it be there. We're totally fine. The
It's a
LED
small
is
vessel.
it's kind of a little bit of a dual LED system with a septal and a major diagonal, so it's fine where the wire is.
Okay, you're
All
ready
right.
for the OCT.
Okay,
Yes.
guys.
For the OCT,
Well
the
done.
system again. Got it?
Yes. And if you see,
Definitely want to
entire
see
case,
this
we have
before we go to
not,
Emory.
Left main, the guide. Yes. And the left main, we keep the guide out most of the time.
Did assist one.
Let's see. OCT a little bit closer. OCT,
I will see the
very
distal
good.
edge. Yeah.
Ketcha, we're ready for the OCT. Approach the guide a little bit. But the OCT is way distal. We don't need to be so distal.
No, you need to see the distal edge. Okay.
Let's see this OCT image because then we have to go to Emory, guys.
Okay, one
Okay,
second.
go.
A little bit back. A little
Enabling.
bit back.
No, it's
The
good.
OCT a little bit back.
Okay.
Okay.
Can you pull back your, because we want to see if you're covering the,
Yeah.
Sorry.
yeah, pull back your,
So
Catch it.
one
We're
second.
not ready.
1 second, please.
Let's try to do it again.
I will skip this.
Precious.
Okay.
No, not so much. You're in the diagonal now.
Okay.
can you,
Okay, let's go. Catch you.
can you
ready?
disengage
second.
from the, disengage from the
Enabling.
ostium?
1 second.
No. We need that. No, we
Calibrating.
cannot. We need the die.
Yeah, please.
No,
see
because
it.
you won't get the contrast into the distal. The
Yeah.
reason to do this
the
OCT
issue.
at this point
Yep,
is to
do it
make
for
sure the
image.
distal part is okay. Frankly, from a workflow standpoint, oftentimes
worried
what's
about
easier to
that
do is to do your
ostium.
pot and your post dilatation and then do your imaging. But I think in this case, the key is what they want to see what's going on distally, which is why
Let's
this
take
run.
a 4.0 high pressure balloon. What do you think for the left main?
No, left main, we have to short stent because it's
It's
not
full.
covered. Wait,
Yeah, 1
let's see.
second, I will check
It's
it.
fine.
The left main.
Kiski just show us a distal edge and proximal edge.
Sure. Now coming to the distal. Yeah, perfect. You see the perfect landing. No malposition, no dissection to the distal edge. Now coming to the proximal edge. Yeah, stent is all well expanded. Now come to the left main. Now come to the osteo left main. Oh yeah. It's not. But just after the guide, the stent start. Of course, it's a little bit smaller position, but it's just
a little position that left main
next to the nodule. It cannot be.
So got us a 4-0.
So we nailed the ostium.
Yeah.
We nailed the ostium. 4-0-15, please.
So we are going to post-dilate the
I
left
don't
main.
know that you nailed the ostium. I'm not 100% sure, guys.
You don't know what the ostium. Okay, let's go to the cranial and show that.
Guys, so we can
we should
see the osteo left main, of course.
Let's go.
You can't see the ostium. That's why you may, honestly, you may to nail the ostium, might need to use a different imaging modality, but it's okay.
Yeah.
Let's see.
No, but actually, even with IVUS, you'll never be able to see the
You'll never be able to see that.
ostium very well. It's only angiography. Okay, let's see here. So let's do a poor man's. Okay, let's get.
But the ostium looks mostly covered. There is only like one quadrant without a stent strap, but at that segment, the area is pretty good. So, and actually, by this OCT imaging, I don't think they need an extra stent. It is
I don't
good.
need an extra stent either.
I agree with you.
Oh, looks great.
Yeah, I don't
But I
think you
think-
need an extra stent. The panel here feels like you have covered the ostium for the most part.
Yeah.
But you
So
need to
maybe
post
you
that.
can
I
just
think
go with your
15,
4-0
George, maybe
balloon.
too long.
That doesn't-
The 15 may be too long. I don't know, George. You have to see because you don't want
Yeah,
to hang
probably
out
an
beyond the
8.
stent. And
Yeah.
8 would probably be a
They
better
cannot
choice
hang
than
out.
C.
4-0-15. We're putting a 4-0-15 high pressure balloon to balloon the left main from the and do the pot.
Yeah,
Yeah, I
but you're
probably
going to
would've
hang
gone a
past the
little shorter.
bifurcation.
To be honest, but-
What, Roxana?
No,
No, I
I
mean,
would
it's
have
just you're either
chosen a
going to.
shorter balloon.
Why?
No, you're
Oh,
going to
good.
see this is 15.
That's
Look at
15. Look at it. Let me show you
Look at
where
the
it
line.
is a 15. It's
Yes.
exactly,
Right.
exactly.
Go
It's
up.
perfect pot.
Yes.
You're
Yes.
ballooning, I think,
Okay.
the ostium outside the stent, in my opinion. But
Hmm.
the stent ended inside that portion. But
Yes.
I think
and that's the portion you're not going to be able to see by OCT.
The ostium not
because-
covered.
But you can see that the stent does take a bend there. Very good.
Okay, no, low pressure
on.
because 4-0.
Oh, wait.
Left is about 3-5, so just go about 10-12. Good.
All right.
Okay,
We
good.
do a
I mean, normally you do this in LAO caudal to make sure that you hadn't got your post-dilatation balloon into and beyond the bifurcation.
Caudal, we requested. Move the things a little bit down, please. LAO caudal. We come into LAO caudal. All right.
Just to make sure the distal placement of that balloon, it's usually a good option.
Well, guys, you've done a great job. We're gonna
Yeah,
need to
very-
go to Emory. They're waiting for us.
Well, it's very clear
Beautiful.
over here that we are nailed the ostium. Thank you very much for your
Looks really good, guys. Great job.
Dr. Kini.
Nice
Thank
job,
you,
well
Dr.
done.
Kinney. Thank you,
you.
team at Mount Sinai. You make us proud. Beautiful job, guys. Beautiful. Thank you. Let's go to Emory, to Atlanta. Hello, team.
Hey,
Dr.
how are you
Jabber and
guys?
Dr. Nicholson.
Hi, good afternoon.
How are you guys?
Hey, Roxana, how are
Good
you?
afternoon. What do you got for us?
Good to have you guys. Yeah, thank you very much for having us. Exciting to actually learn from the panel, hopefully about some calcified nodules and ostium of the circ. I heard maybe similar to the case you had before, but maybe we have a little more different challenges. We have a great team here. We have Hannah, Shanice, Leanne, Brendan, and Elsa. And I have Bill Nicholson next to me. You guys know him very well, and our great interventional fellow Mariam Sawan, who'll be doing the cases, and we'll be here, kind of like talk about it. So, do you want to show the slides, please?
Yeah. Okay.
Go ahead.
Next slide, please. Next slide. So our patient here is a 72-year-old with plasma case of hypertension. He is very physically active. He presented to an outside hospital with chest pain on exertion, found to have an NSTEMI. He was admitted and underwent a left heart cath at the outside facility, and that showed proximal and ostial LAD disease. He was transferred over here to Emory for revascularization. He has an EF that's normal, 60%. Next slide. So these are the images that we took last week. As you can see, he has severe osteal and LAD disease, proximal LAD disease. And at first glance, you think that the osteal circ is not that severe. But if you go to the next slide, you can see on your image on your right side, there's haziness in the osteal circ. So at that point, we decided to IVUS both the LAD and the circ. And it turns out that both of them, the ostium were involved and they were severely calcified with a calcified nodule. So we referred the patient to CT surgery, and he underwent a robotic lima yesterday. And so here's here for complete revascularization for the osteal circ.
All right, let's show. Great, thank you, Mariam. So what the guy did is a lima to his LAD, which looks great. Can we see the live, please? We usually bring these patients next day for completeness of revascularization, and we shoot the lima. Looks great, and so that's out of the way. And now we have that circumflex ostium here that put a guide in it. Mariam wired it, and we IVUSed. Bill, do you want to take us through the IVUS, please, over there?
Sure. So it doesn't, I think Wissam and myself and everybody else had the same opinion early on when we looked at this. I did not think the circ was very impressive, but you can see downstream it's a big vessel. It's a 5.0 at a minimum, but as you come to the ostium, you can see there's clearly concentric calcium gets quite tight. It's about 2.0 residual lumen at that point. And it's concentric calcium. It's not for a long run, but it's a nodule encroaching in on the lumen, pretty focal, and then obviously a big residual left main to work with. And so these are, I think, still very challenging cases because we've got all kinds of calcium modification modalities, but I think we still aren't quite sure what to do with this nodular calcium like this. And I think I'd like to hear what the panel thinks about the strategy, whether a hybrid revascularization with the robotic lima and coming back for the circ left main is reasonable here, whether that would have been something most people would have intervened on completely, or is this something people would have handled surgically completely? And then maybe what your strategy is now for nodules and how you're going to approach these.
Yeah, thanks, Bill. Those are really, really great questions. We have a fantastic panel. Maybe I'll start with really, I think it's just so nice to see hybrid revascularization. As you know, your group has been really leading the way, and I know that we worked hard to make sure that we could have a hybrid study, and that study, unfortunately, due to lack of enrollment, was stopped, the one through the NIH. And I think it just seems like very likely that in certain centers where there is robotic work, where there is, having a robotic lima and then coming and taking care of the circ seems very, very reasonable. And I think it's a very, very nice strategy here. On the other hand, dealing with this huge calcific nodule in a big vessel is one that I think should open up to really good discussion. So we've got Ajay, Kirtane, Natalia, Pinilla, as well as Joost and David Hildick-Smith, and all of them have a lot of experience here. So let's hear from you guys. And Natalia, we'll start with you. You do a lot of imaging. What do you think about this? I mean, how does IVUS help you? I know you're more of an OCT lady, but tell me, how does this help you evaluate what should be the best possible approach in modifying this lesion?
So this location, the anatomic location, I think we have learned the ostial circumflex likely will have nodular calcium. And I think the big imagers, we know that when we see haziness in the ostial circumflex, it's because a calcium nodule is going to be there. So I think it's a great approach. I think no stent should be deployed in an ostial circumflex without imaging, and I think it's clearly evidence here. The modification, I feel biased towards how frequent the stents fail in the ostial circumflex, and I think that pushes us as operators to do a great modification. And even though we do a great job modifying these nodules, the likelihood that these have recurrent events is actually quite high. This is a large vessel, like a almost dominant circumflex large vessel with good lumen. So actually, this is one of those cases that you think about CSI as a good technology because it's a large vessel with good lumen, and probably the orbital would do a good modification. It's like one-side nodule. So in these ones, the balloon technologies, we are not sure exactly how the plaque morphology will come across. But I would love to hear from the other panelists, how do they feel?
Yeah, let's hear from everyone. Ajay, you're leading the Eclipse trial. You're going to look at orbital versus not in this patient population. Very interesting. What do you think?
Look, this is a tough case, and I know that Bill probably thought hard about this because the challenge is hybrid is a great strategy, and especially with a minimally invasive lima. But osteocirc tends to re-narrow, nodules tend to be issues. I'm not fully convinced it's a nodule versus 2 plates of calcium, but either way, this is a pretty high risk area for restenosis. And if the patient's already gone for cabbage and then your stent fails, that's not great, although he didn't have a sternotomy or the patient didn't have a sternotomy. So I know you guys thought about that a lot. And I know we're talking a lot too. So if you want to keep working, we can do that too. But my sense is you just have to do a really good job. And we don't know what the best way to do a good job is here.
Go ahead.
Whatever you're going to use, you got to image after you do that job. And whether that's debulking first, whether it's NC balloon cutter or IVL.
So what would you do, Ajay? What would you do here?
I probably would still
We
start
heard orbital
with an NC. I would probably do an NC image, see what it looked like, and then probably go IVL if it didn't look good enough, or cutter or something like that. But every time I'm convinced I know.
I'm hearing rotoblader.
Case, yeah, the next case I don't know. So that rotoblader is great. That's good.
That's what we would do. That would be us at Sinai. Joost, what would be yours? What would be yours?
This is a great case with a lot of items for discussion. One short comment before I answer. What if you would have known that this was the type of calcium that you were facing with at the time of the diagnostic cath? Would your request to the surgeon have been do a lima-rima?
Bill?
So that's a great point. And honestly, I think that isn't a reason why before you refer, it's good to do the imaging if you can. So then, because it changes how you formulate the case in terms of the long-term prognosis for the patient.
Yeah. Absolutely.
I think everything.
Yeah, here I agree with Ajay. I would just take a non-compliant balloon, see if it or even crosses, because this looks pretty tight. And if that doesn't, I think the atherectomy here looks to me a reasonable strategy.
What are we doing?
Bill, you were saying something, I think. Sorry to interrupt.
Yeah, Bill, go ahead. Go ahead, Bill. We interrupted you.
Yeah. No, I think that this is an area that we certainly have the same concerns that the panels express. It's an area of common restenosis, and I think, and I don't think clearly don't have a great understanding of how to treat nodular calcium. I think a full arterial revascularization would have been a really nice option here. I would not have been against that strategy. You can see how Wissam's completely ignoring everything everybody's talking about, just doing what he wants, but that's good. So, I think it'll be an interesting strategy. The patient really didn't want a sternotomy, so I think this definitely addresses the LAD territory. If we have to keep coming back for the circ, then I think we'll be shown to have made a mistake. The funny thing about these is when they're eruptive nodules, they come out looking great now, and those are the ones that are going to grow back. And so, I think it's a tough place to work.
Because
that's a
175.
It's a 175.
Okay.
I think that's
to
to Natalia's point about the OAS versus the rota. You want to make a big lumen if you're going to do it this way.
Yeah, so Roxana, my only additional comment to what everyone said so far.
You want to do 5.0 non-compliant, or do you want to do something else?
The left
we have a 5.0 non-compliant.
Is very likely to give problems in the medium to longer term. I would be using a cutting balloon here if necessary, IVL. And the only additional comment I'd make is if there is a possibility to avoid implanting a stent, we would also look at that with drug-coated balloons here. I know it's relatively unlikely looking at the anatomy so far, but we would at least keep that in mind.
Yeah, that's an interesting concept. Bill, what did you think about that? So it looks like you're going with a non-compliant balloon here, which is reasonable to see how
We did
you
one
do.
Rota run with a 175, and then we're going to do a 50 non-compliant, see how the nodule behaves. But I think we have Shockwave sitting here in the room as well. I'm not to the point where I'm got the experience with DCB to walk away with just a DCB and no stent. It's a attractive
In such
thought,
a large
but,
vessel.
We'll see where. We'll see where that goes.
Very interesting.
But by the way, in this shortcut trial that we're doing comparing IVL to Wolverine, there's stratified randomization. So if you do Rota, you can still be in the trial. You just after Rota, you're randomized to IVL versus Cutter. If you don't do Rota, you're just randomized to IVL versus Cutter. So I think this would be a great case for something like that because again, we just don't know.
No, I think in my mind,
very, very nice.
Circumflex nodule. When I see osteal circumflex nodule, I really want to, at least in my practice, want to modify it as much as possible. So I tend to do a lot of combination of Rota and Shockwave.
Mm-hmm.
The advantage of that is if it actually fails, then you don't know which one to blame.
Yeah, that's good though.
Good one.
But David, I love your comment about this drug-coated balloon because in North America, we don't have much experience using them. But I have had cases that I have decided to put the stent in the circumflex, osteal circumflex, and do drug-coating balloons in large rainbows on osteal LADs. And then the one that fails is when the stent is, and the drug-coating balloon segments are good. So I think in North America, we need more experience, and we haven't got to use them that much. But I know you guys are pretty confident using them in your practice, so I think we had a lot to learn.
Yeah.
So Bill, tell us, how did that feel? That non-compliant balloon went over well? Did it dilate well? Because I didn't see and how much did you go with your pressure?
Yeah, I went on pressure to 16 atmospheres on this. It's a 5.0 big balloon. I don't want to go too high, but you can see that there's a little bit of a waste you see in the middle. We're going to IVIS just to kind of show everybody what these modalities that we did showed, and then we'll decide on a Shockwave after that.
It's a location that OCT would be nice. I mean, to distinguish whether it was a smooth nodule versus an eruptive nodule, but it looks like there's a little marble at the bottom there, so I suspect this has probably got a significant smooth quality to it.
Okay.
All right, that's good there. All right. Can we have the IVIS on the bigger screen, please, Vladimir? Thank you.
There you are. You've done some good cracking there.
We're not quite there yet. This is...
Yeah, there you go. Here you go.
It's pretty
interesting, huh?
Yeah, let me...
It's like almost two areas there, you know?
Again.
Yeah, these are shells of calcium that are overlapping a little bit. I would bet that these will they will yield if you put in this.
This is going to be good. Yeah.
It feels like there is that I feel like it's going to give. I feel like it's going to be okay, but I could be wrong. I don't think you need shock
volume,
wave.
right? We cannot take
we're
away
fine.
the volume.
Would you all do anything else? Would you shockwave, or would you just go ahead and stent and high pressure balloon?
Yep.
I would go ahead and stent, but I don't know. What is the group think here?
Well, I must say, I thought it looked like it needed a bit more work first, you know. I take cutting.
Now that it's modified, it looks like a 3 quadrants nodule now, right? So I think the nodule is more extensive than what we thought initially, because you see like the shape of the rota, and now almost 3 quadrants have this calcium. Like I think the nodule is interesting because even if you put a stent, it's gonna open for sure. I think if you put a stent, the expansion is gonna be good, but I'm not sure how much modification we have achieved in that nodule by now.
Yeah.
So what would you do?
You know, what's
you want to
interesting,
go with
More out?
We decided to.
Sounds like you're going with a
We had it
shockwave.
open, unfortunately, first.
Yeah.
Yeah,
That's good.
I mean, like some people said that there's still some more modification that needs to be done, and it's going to be helpful with this nodule, I think.
Yeah, I think that
Can you put the fluoro in the main,
Can you
please?
turn the
Enable
telephone on,
Put the
please? Yeah,
fluoro in the larger screen, please.
You know, I was going to say, you know,
Thank you.
we don't know a lot for sure with this case, but one thing for sure, in my opinion, is that after you've done that IVUS, if you're going to do something else, you don't want to go up higher with an NC balloon or a Wolverine or something like that, because you have
That's
three
right.
quadrant modification.
Stay
It's
here.
going to expand on the opposite
Proceed.
wall. So I think if you're going to do something else, the only thing you should do is do IVL. Otherwise, you really are going to run the risk of perf or something like that. So
Yeah.
it's just, you know, it's a, I
Did
think
it
this is a
perforate?
reasonable strategy for sure.
No,
No,
we're just
it was just too distal, so we're coming back on it.
Oh, okay.
Yeah, go up here. Yeah.
That's nice. That's straddling nicely.
Yeah, we still have to go backwards a little bit and do it, but we'll
Yeah.
do a few pulses down here.
Mm-hmm.
Well, now with 120 pulses, it gets a little boring because you have to wait longer.
Yeah. It's a large vessel, so.
Yeah, come back a little
You
bit.
want me to pull back?
Let's do one more time here and then come back.
And you know, this is the existential question with IVL: is that, you know, if it weren't so expensive, you know, you're only inflating the 4 atmospheres. You're doing calcium modification. Everybody knows how to use a balloon. The only problem with it is the deliverability of it. But overall, this should probably be the safest thing we can do. But I think you need some head-to-head data to really feel confident in that. And that's why oftentimes we sort of opt for other approaches, perhaps first for cost reasons and otherwise.
Yeah.
Yeah, if we follow this up with
Yeah, no,
PCB,
it's
we
good.
can make the most expensive osteocircumflex in the world.
And if you don't put a stent in, the hospital will likely kill you because of the reimbursement issues.
Very interesting.
But I agree with Ajay. It's
I'm gonna
similar
go
to
get
the
the
other
answer.
case, the 92-year-old patient. We feel so safe using the IVL. And I know we don't have randomized data, but we just know it's such a safe device that we will use
And it's the
it,
reason
like,
why
even-
it's highly used now.
Yes.
I mean,
Yes,
except for this thing
totally.
of the rupture thing, which happens somewhat unpredictably, is a little bit concerning, but it's a very low frequency event, I think, overall.
Yeah, very low frequency. That was the first time I ever saw one at Mount Sinai, to be honest. Very low frequency.
What did y'all have earlier?
We had a rupture of the
IVL
IVL
balloon ruptured.
So,
in the left main.
yeah, I'm not seeing as many of these.
We had the
I
first
mean, it's-
perforation with the IVL balloon of the coronary that I've seen last week. Didn't rupture the balloon and extravasate, and it was actually a real rupture into the pericardium, self-contained, but purely just doing this at 4 atmospheres. And I've not seen that, and I don't think it's been reported.
No.
Well, Bill Emory certainly is known for a lot of firsts, so there you go. And some of them, most of them really good. Most of them good, yeah.
Thank you. For the nice transparency. I think I'm
Thank
doing
you.
the right spot here.
Yeah, do the last
Yeah.
20.
Yeah. All right, go ahead. That's enough. We'll take the NC.
So in a real fair question to you, Ajay, and maybe Roxana can answer better. This is being done in the same visit as his bypass. So how does this work out? Is this all complementary?
Yeah, it's a great question.
Very good,
I
good
have
question.
to, that was, I think, one of the reasons why hybrid didn't, take off as much was because typically for DRG and all that, it's billed under the same visit. And so that's why, out of practicality, if it's not super bad, a lot of times patients will come back and have these done in the staged procedure. Some would argue also if there's a bleeding issue or something like that, there can be some safety issues. But I think people do it a lot of different ways. Some people will even do the PCI before the CABG or at the same time. They anastomose the lima, and while you're on pump, then you do the circ and you give the clopidogrel or something like right at that time. So a lot of different ways of doing it. Why did you choose to do it this way?
Too far.
Bill, was it more convenience for the patient? Or is this how you're normally doing it?
Yeah, Mike Halkos is really good at these, and I think we routinely shoot him afterwards because I think he's in his own intellectual honesty. He wants to see the anastomosis and continue to learn from anything he would have done differently. And I think from a patient convenience standpoint, it's nice for them to get home in just 2 or 3 days. But I don't think there'd be anything wrong with bringing them back or doing it in a staged fashion. And I think the bleeding concern is a real possible issue, and I think it depends on how critical the residual disease is. I would have been comfortable letting this guy go home and come back and do this at a later date.
So is this your balloon again? Your NC balloon?
Yeah, that's the balloon. I just want to.
It is. It's back at 16.
You want to get a better? It looks like you dilated better.
It did. I think we want to IVUS one more time just for everybody's enjoyment. Not that we would do this if we weren't on TV, but we can do a quick IVUS run and show what we look like, and then we'll stent and post and re-IVUS.
I mean, either way, this is a super interesting case for a number of reasons, and you proceeding through it really logically, safely. So it's a great demonstration, especially with the other one as well.
So you guys felt like you really needed to do some more work as the nodule sort of spread into different shelves of calcium, but to me it looked like it was all broken up and that you'd be able to expand the stent, but maybe this is now going to help it even better because it looks like your balloon dilated so much better. Let's see what it looks like by IVUS.
Let's put the IVUS on the big screen, please, Vladimir.
Yes, please. That'll help us. Yeah, great.
I don't know if that's a hematoma or just part of the shelf.
No,
Might
that
be a
was the shelf, I think.
pseudostenosis or something, or
Didn't really change, huh?
Yeah, it looks kind of similar, but look, I think you have clearly done
A little
everything
bit better,
you possibly
though.
could do. So it's, I don't know. I don't know if it is, but I think you feel better. That part I'm a little worried is a hematoma there, but I think you've done everything you could do, and now isn't the time to stent. It looked a little.
yeah, we're gonna go ahead and stent now.
So lots of people are asking questions online. So one of them are asking, are you going to cover the left main all the way, or are you just going to stop short half of the left main? And then the size of your IVL balloon was a 4.0, right?
Yes, it was.
Bill?
That's the largest.
But we don't have bigger, right? There's
Yes, it was. That's the largest corner. Yeah.
the guide.
Okay.
Are you able to hear us or no?
No, we hear
I
you.
think you've
We hear
lost our
you.
Can you
volume.
guys hear us? Oh, perfect.
Yeah.
Thank you.
No, we hear you.
So
Can
we
you
were going to
hear
come
us?
all the way back to the.
No, this is too
Can you
far.
put?
Yeah, it's a
put
little
the
bit of a delay,
main-
I think,
Can you
but,
put the
you-
main?
On this.
Can you put the angio on the main screen, please?
Put the floor as the big screen.
Thank you.
Thanks.
Yeah. Thank you.
You went in.
Were you having a hard time going in, Bill? With the scent or no?
No, that's just the stent went too far, and we're bringing it back.
Okay, you're just bringing it back. Yeah.
Yeah, and it's hard to tell on this view where the ostium of the left main is. I'm gonna go to a different view in a second.
You want an oleocranial?
Yeah, let's go oleocranial. Oleocranial is the best view to see the ostium of the left main.
Can you tell us the size of your stent and what you're planning to do? Are you coming all the way into the ostium of the left
It's-
main?
Yeah, we are going all the way to the ostium of the left. The left main is short, so we'll have to cover it. It's hard to tell where things land.
Yeah.
And you see the calcium here on top of the left main in that view. And it's a 5024.
Oh, wow.
Yeah, that's what the measurements are. The left main is even 6.0 here. Oh, that's too far back, I think. I don't want to cover the ostium that much. All right, let's take a picture here, Bill. Good. I don't mind that.
It's good.
I don't mind it at all. Let's go call, make sure we cover this circ distally. Yeah, I like it. That's good there. Picture. That looks good there.
Yeah.
I would not go high pressure on this distally with 5.0. Good.
20.
All right. No, not 20.
No, I'm just kidding.
Well, thanks.
But definitely pull back to flare it in a little bit in the ostium. So
Yeah.
You want to post it with a 5.0?
Yeah, let's give me a 5.0, please, here. Give me a fresh one.
very nice.
Non-compliant balloon.
The left main was at least 6.0, which is, again, a challenge in terms of sizing. We should be able to bump it up to 6.0.
Post this real quick and then get a picture, and I want to re-IVUS it and see what our MSA is.
Yeah. Let's take, yeah. It's 3 p.m., so yeah, let's show.
We'll take that here. That's perfect.
We're almost out of time, but we really want to see the final.
Yeah, let's do an IVUS kind of.
You want to take one good picture here?
Yeah, let's take.
Sinai.
Go ahead. Good. Ah.
So there's a little perf up above there. You see that? Right above the top. Maybe that's a little branch coming from.
There's a little branch there. That's not a perf.
I don't think it's
I'm
a
more
perf.
concerned about what's
You
going
think
on.
I don't think it's a perf.
No, it's
IVUS will show you, but I don't think it
The
is.
distal part is the only thing is the distal.
Distal. Yeah, distal looks like.
Yeah. Is there a distal haziness?
I don't like it.
Mm-hmm.
Yeah. IVUS, not
IVUS.
NC. Oh, IVUS, please.
IVUS will help you
I
a
wanna fix
lot
that
here.
distal issue here. Yeah.
Yeah, there's a little distal dissection.
And also the flow in the LAD is probably likely to be what Ajay says, that there was probably some hematoma that now sent it into the LAD. Could be the way it looks angiographically.
That's good. That'll help the IMA continue to mature.
Let's put the IVUS, please, on the big screen because we need help from the panel.
Is it pulling back?
No.
I don't know.
That's a good question. Oh no. Okay, that explains it.
I was going to say,
All
how
right,
far
let's
down
go
did you
live
guys put
again,
the
Bill.
IVUS catheter?
I was wondering, like, it looks great. The stent looks wonderful. All right, good. Again.
See, this is what happens if you do it in
No, it's
normal
cool.
vessels. You know how to recognize these important things that happen.
Yeah.
Oh, the edge looks
Oh, the
perfect.
distal edge looks
That's
good.
fine.
It looks pretty good.
It looks fine.
It's pretty good.
Yeah.
So it's just a calcified shell.
I think the area is good. Like, yeah.
So far, so good.
I mean, the stent is D-shaped, but
Guys,
the
it's
area looks
looking
good.
good, guys.
I'm not worried.
It's very good. It's very good.
Yeah.
This is
It
also
looks
one of those
good.
where if you
Guys,
didn't
looking
do-
good. Looking good.
If you didn't do imaging, you'd be taking 18 views of it and trying to convince yourself that it's okay. Just figure it out and then do this, and you'll know. So this is great.
And I
Then
find
maybe we
Really,
can
really
put a
good.
stent
I don't
just
think
to-
you need any more post-dilatation.
by angio, I think it's dissected and you do imaging, and if there is no distal ace dissection, actually this is quite common. So very good learning point.
What are you doing now?
We're
I
going to
think you
just
look like you're
optimize
good.
left main. We're going to optimize the left main. It's pretty, the stent
there's a
is
little
small
ballot
for the
position,
left main. So that's what we're doing. And that's it. Yeah.
Oh, it
Left main
looks
was
pretty
pretty big.
good by Ibis.
That's it. And then we're done. Yeah.
Okay.
And are we okay transmission time wise, everybody?
Yeah, I think, we're really, really impressed with your work. I think what you've done is beautiful. Thank you so much for this wonderful case. Really beautifully done. And I can't imagine doing this without imaging. Honestly, beautiful. Thank you so much. Thank you.
Yeah. Thank you.
All
Thank you
right.
for inviting
Well,
us. Appreciate it. It's always good to hear.
Great to be with you guys. Thank you. Thank you, Emory. Well, this has been a fantastic session. And we're going to, can you imagine any of those cases without imaging? We're going to come back to you guys to say goodbye. But let's go to the wrap-up video, and then we'll come back and say goodbye to all of you. Thank you.